Good afternoon, everyone. Thank you for joining our online semi-live today from Gleneagles Hospital, Kota Kinabalu. My name is Lucy, and today we have Dr. Jiann, our visiting wound management, to share with us on the update of wound management and its dressing. Allow me to brief you a little of Dr. Yap's background. Dr. Yap graduated from medical school Jiann University in June 2000 as an undergraduate. Then he came back to Malaysia for healthcare services after passing the local exam in year 2005. Since then, he works as a medical officer in year 2007 after 1.5 years of housemanship since 2006. He was assigned to lead the wound stoma care unit in 2013 after 6 years of surgical training. In 2014, he was officially being appointed as the head of unit in Queen Elizabeth Hospital. Then in year 2015, he was appointed by Sabah State Health Department as Sabah Head of Service for Wound Care. Then he embarked in Master Program of Wound Healing and Tissue Repair in Cardiff University under Professor Keith Harding in year 2015 and graduated in 2020. His main task is to manage pressure injuries patients and other types of wound, planning patients for hyperbaric oxygen therapy, conduct research and study in the hospital, also teaching and training healthcare people who have the interest in developing wound stoma services. Given the opportunity in organizing conferences, workshop, training at the state and hospital level. So if you have anything to ask Dr. Yap, please send it to the comment section, and Dr. Yap will try to answer your questions towards the end of our session. Without further ado, I will pass this session now to Dr. Yap. Good afternoon, Dr. Yap.
Good afternoon. Thank you very much for your kind introductions, and thank you very much again for the organizers for a lovely platform. During this pandemic, I think this is very suitable for us to meet up virtually and to share whatever things that we know in our healthcare systems here. And today I was given a task actually to share or to introduce about wound management. I would say maybe an update. The reasons behind it is because wound management, I think those days, all right, the moments that we talk about those days, like olden days, when there are documentations with regardless of whatever kinds of language or whatever kinds of written or wording that we know of, as long as there's someone have any documentations, already wound management is already on the spot. However, during that time, I think in these articles that were published in 2007, okay, they will be talking about like before this, they will be using all sorts of natural resources that we have, you know, for the coverage of the wound, for talking about wound healings and things like that. I believe that something that was listed down here shouldn't be any strange to any one of you guys, which I believe some people may have heard it, usings of honey, usings of plant-based, using of the animal fat and so forth. Now, I think from here, I have a lot of slides today, which I think I'll be sharing of like what kind of wound management that have been developed for the past 50 or 60 years. Yes, it's about 50 or 60 years. Instead of like using gauze that we all know of, commonly that we train in our medical school or during our internships or housemanships training in the universities, hospitals, most of the time that we're using gauze and things like that. But recently, I think for the past 50 to 60 years, a lot of things has been resurfaced. A lot of study has been done, especially wound biologies, in deeper understandings about wound management, or different types of hard to heal wound now called, or some people call it difficult to heal wounds nowadays instead of like wounds, chronic wounds. Okay, so a bit of a history. This guy was actually the father of medicine. He was a French surgeon actually. So what I'm trying to bring up this guy is that what he did during that time in the French War in the 15th or 16th century, he's actually found that to manage wound, we need to manage it, you know, gently rather than too rough or things like that, because otherwise our body will create more and more inflammations. Of course, during that period of time, nobody knows about inflammations. But nowadays we know that as long as you have an injury, inflammation will set in. I think inflammatory nowadays is nothing new to every one of us. It's not so strange because I think with the pandemic we all talk about the complications from the inflammations that the disease can derive to. So that's why because of that, a lot of things has been coming out. You know, we have gauze around here, you have Nomisaline, and then we have povidone iodine, chlorhexidines, and then whatever they call it, flavin solution, like a yellow types of yellowish colors, or socoserials, or maybe something. So what are these talking about? Was actually trying to, as long as we have wound, loss of skin, we're just trying to cover it up. Okay, so hopefully that our body will actually do the healing. Well, actually, to be honest, all the healing process is actually done by our body cells, our human cells itself. Okay, including what I'm going to talk later on is all done by our body cells. Now, why gauze is actually developed is because gauze was actually during the wartime, they need something to manage blood. So they need something to have a very, very good absorptions. So that's why gauze was actually been developed. So in terms of this, like I think our organizers, our chair lady was mentioned, I was being appointed as a head of the wound management since 2014 and 2015, looking after the whole state of Sabah here. So when we talk about wound management, people may think that this is what we're actually managing, but actually for the past 20 years, we all know that most of the time that we use all sorts of dressings. I think the first thing we all know that similarity is to cover the wound or conserve it, and then they'll come up with this moist wound healing concept, which I will introduce to you guys later on, and also followed by the wound bed preparation. But actually, in the reality, a wound healing achieved by patient, actually you have to take into considerations about the nutrition, the mattresses, the psychological status, and also the blood sugar levels, and of course other parameters as well, debridement, infections control, and moisture healing. I think this part of this knowledge here, I may not be able to have the time to share with you. Like I say, even though I need to study about like 3-4 years in a master program. So with this 1 hour, sharing moments, I don't think I can have the time to, or the luxuries of times to share with you. However, if time permitted, when I finish my presentations, if time permitted, I may share with you some of the cases that I have gone through and managed in my unit here. Now actually, in the actual fact, wound management, this is what we are dealing with. You know, all the 4 pictures here with the different types of leg ulcers have a different diagnosis as well. And also the other parts of the world that have, some have a lymphedema, or some may have a funculating ulcers, which is indicated of a cancerous types of wound, or maybe elderly people, geriatric cases as well. Now, in these modern days, I'm sure something that you may come across like gauze, foams, hydrocolloid, alginate, honey, collagenase, and things like that, that we may be coming across because of the understandings of the current developments about wound healing. Now, the concepts of wound healing, I believe this is all from a medical school. There's nothing new to us. Now, what I say is that the wound healing is based on our human body. By looking into this graph here, you can see that it's all our cellular level that do all the healing process. None of the fiber or dressings that come into play in this part. Then why are we developing or manufacturing so many types of dressings material in the world or in our market? All right, because of this guy, George Winter, in the year of 1962, he published articles because in the Second World War, and then a lot of the warrant doctors in the who work in prison, and then they've noticed that those prisoners who are being burned because of bombing and fire burning, they were being burned, and then they found that by using a transparent film and adhesive dressing, okay, instead of like cover them with gauze, they don't have a burn gauze or something, they just cover up with an adhesive dressings. To his surprise, by the time when they remove the adhesive dressing, the soldier or the prisoner are actually encounter less painful. All right, so they just publish it, but don't know why. So this Professor George Winter was actually trying to do a study on an animal, and you can see that this part here, number 5 here, was actually covered up with a thin layer of an adhesive film. And this part here was actually being exposed, just like us, right? You can cover up with gauze, you can cover up with anything. So they found that there is a capture of the moistures around here, okay, a fluid, exudate fluid, while this part here was actually become dry and it was having scab formation. Then they found that on the left hand side of the healing, it was actually 4 days faster, all right, as compared to the right hand side of the healing, which he actually did it on the same animal, but at the back of the trunk of the animal divided into left and right. And the depth is only 0.05 millimeter, very, very superficial, not even 1 centimeter deep. And he found it and he published it in the year of 1962. Unfortunately, I think people doesn't believe it because this is something new and nobody understands what's going on. And he actually promoting this moist wound healing concept. 20 years down the road, he was being, not to say terrorized, but people was actually condemning him for causing more and more infections because of the keeping of the moisture of the exudate under the adhesive film. You'll be promoting a lot of these infection. 20 years in 1980s, there are actually 2 scientists, Lawrence and Hutchinson, were actually published in American journals and confirmed what Professor Winter saying is true, because they did a biopsy on the wound site where it was being covered with adhesive film and found out that a lot of the macrophages was actually found alive on the wound bed, which is outside the blood vessel. Whereas on the right hand side where scab formations, all the actually live or healthy cells was actually buried under the tissue. But this part here on the left hand side was actually on the surface. So actually, with all these kind of white cells was actually found atop on the wound surface and alive, actually it helps to govern the infections around that area. So since then, a lot of a company developed different types of the materials and trying to have better understandings how are we going to create a moisture balance, which I'm going to introduce to you guys in a short while. So Professor Harving in 1992, by understanding the wound healing matrix, was actually, first of all, the 4 phases that which I already introduced to you, and then we have to understand the etiologies, followed by the clinical manifestation, and of course the environment and care definitely is very, very important. Like us in our country, in Malaysia, we are having temperate climate. What about in the northern hemisphere or southern hemisphere of our planet Earth? You have 4 seasons, different types of a climate and environment, and the workers as well. And about of our healthcare systems, what do we have? And of course the anatomy structures where the wound lines. And of course we have to understand about the history and get the full examinations, investigation, because all these things, HIDE is actually a synonymous for history, examination, investigation, diagnosis, and indicators. Okay, what are the expected outcome that we're going to accept? Otherwise, you have to go back again history. It is very, very important because we have to get a full detail of the history. How does a wound begins in the beginning, all right? And examine thoroughly for the whole body rather than treating the ulcer itself, which is not enough. All right, so that's why people say wound care team is actually a dressing team, which I strongly against it, because we need to understand how the wound began, how does it form, and why it is not healed. Our body have a tendencies of healing, but it doesn't heal. Now there must be something wrong somewhere, and this is our responsibility that fall on the physicians to find out what is going on. So these are the risk factors that we can see, which were published in 2015. Venous neck ulcers, diabetic foot ulcers, and pressure ulcers, and arterial ulcers. I believe these are some things that not unfamiliar to every one of us here. And of course, the common chronic wounds or clinical presentation and standard of care, like a venous neck ulcers, people will talk about elevations of leg, or people now go for vein stripping, vascular indication. What about if the patient is unfit for surgery? Then you may need to go for compression stocking. Diabetic foot ulcers, control the diabetes as well, other than frequent debridements. What about offloading? Does it really helps in terms of the healing process? Pressure ulcers, another word we call bed sore, but nowadays people talk about pressure ulcers, or people, I think they will be going to switch the word from pressure ulcers to pressure, injury. So what about too early turning, positioning of the patients, and of course debridement of the necrotic tissue? Does it really help? But don't forget that optimized nutritional status and appropriate dressing, that is also playing a very, very important role. Arterial ulcers, of course, you need a vascular surgeon for have a revascularization. Connective tissue ulcers, the vasculitic ulcer, and mitochondria, microthrombi related ulcers and paroxysmal gangrenosomes. And what about the conditions, the clinical indications that was actually people will manifest to us, and how to get appropriate diagnosis and come up with the appropriate dressing? That is very, very important. Okay, of course, marginal ulcers is nothing new. However, hypertensive ulcers, we call them more martorial ulcers, which is diastolic hypertensive ulcers. Not sure whether you guys have any experience in it, which I do have. What I did is just control the blood pressure. You don't need any special dressings for that. Just to control the blood pressure, especially the diastolic hypertension, once you need to control it, the wound will slowly heal. Simple. So that's why I say coming out with an appropriate diagnosis and to treat the wound rather than putting all sorts of material which none of us or majority of our doctors or healthcare professional doesn't know how does it derive and what does it do. Okay, that will actually spoil or deteriorate the wounds. All right. Oh, sorry. So now, because of this, to understand things about clinical manifestations and things like that, so sometimes we need to talk ourselves and asking ourselves, we manage overall of the patients, all the symptoms. Let's say the patient complained to us with pains, okay, I bad smelling, I can't stand for the smell. What actually we would like to look into it. But however, when we manage it, we manage everything because we want to target for healing. So we cannot neglect just only the symptoms or overall management, but everything have to take into consideration. What about on the wound itself? Are we talking about systemic factors itself? What about the regional factors? Are we taking into the considerations of the regional factors? And about the local factors as well? All these things is actually very, very important because all these things will affecting the wound healing process, the whole process of the wound healing. That is actually affecting a lot. So we are not looking into just purely the system, but the wound itself. So these are the systemic factors, the local factors, and also the systemic factors that will actually compromising the wound healing. Are we able to look into this to sort of like to optimize the disease or to optimize the problem that the patient is having before we talk about wound healing? That's how after that they come out with the wound bed preparation. It's because of the series of the history, the series of the questions was actually being derived. Everybody knows about it. Okay, the risk factors. But what about wounds? But nobody talk about it. And suddenly there is a group of scientists and the clinician was actually talking about wound bed preparation was introduced in the year of 2000. So people was actually asking, what is it? Is it a common sense? Since we are managed wound, of course, wound bed, you need to prepare the wound bed. So it seems, is it a common sense? Are the things that we need to do? Or now something we have to make up a new terms, people want to get their name on the board so that I actually contributed, all right? Or is it something to be more mature in thinking? Nothing new, but you just need to go in depth in understanding it. But in terms of management, it doesn't help much. So people were actually asking why suddenly this wound bed preparation come about? Or is it you're talking about understanding this, it will help us in terms of the treatment plan. So what is it all about? It's actually trying to understand what's going on and trying to remove the barrier and also the initiates the healing itself. So what are the barriers that we can actually talk about? Bacteria, necrotic tissue, exudate management, biomechanical imbalance, and also cellular dysfunction. Now let's take the diabetic foot ulcers for an example. First, we need a diagnosis. Everybody, easy to get a diagnosis. But is it neuropathy or ischemic? Now, when we talk about wound bed preparations, we talk about these few things: bacterial necrosis, exudate biochemistry, and also the dysfunctional of the cellular level. Okay, then we start about to initiate the treatments of the wound bed preparation. Now, the treatments of it, It involves the dressings, it involves the devices, it involves the drugs, and involves surgery because it requires some form of a surgical debridement. If a patient is not fit for surgery, we can do it bedside, and which is majority, 90% of my work was actually done in the clinic, which I actually did it as a bedside for a sharp debridement for patient. Okay, what about biological, which is a types of the advanced treatments that we can actually apply for this type of wounds and this type of patients to initiate the healing? That is the very, very important. So that's how to come up with this time framework. Tissue, infections, moistures, and age. What are we trying to get? We're trying to get a viable tissue, remove all the necrotic patch. If let's say we have an infection, we're suspecting of an infection, we can have antimicrobial topical applications or require a systemic antibiotic. What about the moistures? Because of inflammation due to the infection itself, there will be a lot of exudate was actually being extravasated. Are we able to control it so that it doesn't leak? Otherwise, the patients will say that it was actually dirty. What about the ages of the wound? Can we get a healthy ages so that the wound healing can be actually initiated from the wound ages, not only from the wound bed? So by understanding this, we can actually say wound healing is actually a dynamic process. Not just from the ages itself, the healing process, it also is from the base of the wound, okay, coming up. So it's actually a dynamic process. So this wound bed preparations case cycle, we can start up with the patient, we assess the patients, identify the problems, perform the time assessment which I introduced to you just now, and then treat and evaluate again every time we look at the dressings, we look at the wound when the patients come back for wound management. Is it healing? If it's not healing, go back. Did we miss something? If it's healed, progress it, okay? Try not to change, or you may need to change the dressings to a suitable, to suit the wounds for a further progression, so further development, right? Then recently, for the past 5 or 10 years, they come out with, just now I talked about TIME, which is only targeting on wound. Now this one was actually talking about the wound ages and also beyond the ages, which is the peri-wound skins. How healthy is the skin? Is it a cracking type of skin, dry skin? Is the skin healthy at the site? Because, like I said, you need the epithelial tissue to grow from the site. So advances in understandings, we can have a diverse etiology, complexity of the healing process, multiplicity of factors that we need to look into it, extensive and widening range of the dressing, which I will introduce to you shortly, advances in understanding of the mechanisms of wound healing at a cellular level are actually gradually providing a more scientific foundations upon which to base a treatment decision. There's the reasons why I say wound care team or wound management team is not a dressing team per se itself, because there are a lot of things that we need to look into it before we come out with a treatment plan. Now, let's come to the dressings part. Now, the ideal dressing is we're supposed to remove the excess exudate, okay, and also toxins on the wound bed, and maintain moisture. I would say maintain, or we call a balancing up, not to make it too moist like a flooded, or not to make it too dry, which we commonly do nowadays. All right. So provide barrier to pathogen. By the time we apply the dressing should be able to protect the wound from getting any infections or any microorganism penetrated to the wound bed. And of course, there's prevent trauma, because it's already a wound, you're trying to make it healing, and provide thermal insulations, waterproof, and safe, easy to use, so that the patients may be able to do it at home while they are unable to come for visit in the clinic. Of course, the dressing categories can divide it into a conventional, I believe everybody knows about it, which already introduced some like gauze, things like that. And of course, nowadays we call about modern advanced wound dressings. These are the modern wound advanced wound dressing. It can categorize in a few of this, all right? So I'm trying to introduce some of this to you here, but I'm not going too deep into this, the last one on my right hand side here, which is the regenerative dressings. Okay, from my understanding, regenerative dressings actually talking about MEBO. MEBO stands for Moist Enhanced Burns Ointment. All right. So I'm sure some of you may come across it because it belongs to a types of a herbal ointment that will actually help. So I'm not going into that details, and I because it will be dragging a lot of time after this. So if you want, maybe in future, okay, we can share with you on this part on this particular topics. Now, this dressings category was actually catered into the wound bed preparations design model, which is the TIME that we talk about. All right, let's look at the tissue. So if we want to have a viable tissue, because patient may be presented with sloughy tissue or necrotic tissue itself, the hydrogel itself, it can have a debridement or desloughing purposes, what we call autolytic debridement. Of course, it can rehydrate, and at the same time, it promotes moist wound healing, okay, granulations, cavity. But the problem is the judgment of the exudate level by a clinician. That is very important. Why? Because sometimes we say, okay, I think it's too moist. Well, actually, it's too dry. Not necessarily it's too moist. But sometimes we say it's too dry, I think I need to get some hydrogel. Well, actually, I think it's too moist already. The moment you give hydrogel, the word hydro means it contains water. So you're giving water on the wound bed, it may flood the wound. All right. Until today, I'm sorry to say that we do not have any tools to guide us the level of exudate. Some people say low level of exudate. To me, it can be moderate. Some people say moderate, but to you it can be, no, this is highly exudative wound. So it is very subjective, but unfortunately, until today, if you look into the Western wounds, they don't really have a tools or any assessment to come up with to judge more objectively about the exudate level. So it depends on us. That is the reasons why the disadvantage sometimes it can be macerated at the peri-wound skin, and you need secondary dressings. All right. So hydrogel, just for your information, hydrogel, it contains different percentage of water. So I'm sure some of you may have come across these few groups of the brain. Okay, you can see the water contents are different. It depends on the types of wound, that you will see, and the types of wound that you encounter. Even though diabetic foot ulcers, that if you many or majority of you are managing, but not necessarily that you may want to use a 90% of water content. Maybe you would like to use a 50%. Like I say, diabetic foot ulcer, you have a few classes. Even though if you use Wagner classifications or the Texas University classifications, all right, so because the different classes, the exudate level will be different. That is the reasons why I say wound management is a very, very dynamic. It is something slightly bit different from our usual medical management, where when we prescribe antihypertensive, once we prescribe, as long as the BP is optimized, we will never ever change that particular medication. All right. So, but wound management is different. It is not like how we do prescriptions for antihypertensive or the oral hypoglycemic agent for diabetes control, because you need to look at the wound, assess the wound, and change accordingly. So you can see that on the left hand side, there is sloughy wounds after autolytic debridements become clearer, and then the lower part of the picture was actually a carbuncle, a huge socialization was done, and then you can see it's getting smaller. But beware of over or hypogranulation. Now, moisture balance aim that we talk about, you can have a few types of a dressing material that was actually around here. Calcium alginate, hydrocolloid. Now, what is this triangle here? The tip of the triangle, meaning to say that the absorptions of that particular dressing is actually lesser, but the base of the triangle, meaning to say that they can actually absorb a lot of the exudate level. All right. Now let's look at it. Now, calcium alginate. Now, calcium alginate was actually derived from seaweed. It's because it contains one part of the material called alginic acid. So this alginate is able to absorb. Now, it also can have a high hemostasis purposes if they included the calcium salt into that piece of a dressing material. So it's something that you can actually ask your the marketing peoples or the sales people, the company peoples, is your alginate have a hemostatic effect? All right, and also biodegradable as well because it's from seaweed. I think some of you may have eaten seaweed before. Disadvantages is actually not helpful for a dry wound and need secondary dressing. Now, why not helpful from dry wound? Because like I say, if our level of assessment in terms of exudate level is slightly a bit out and we cannot get it, we think that is moist, we put on, but actually it's dry exudate, but we try to put on the calcium alginate, it will act like a gauze and stuck on the wound bed. And you need to use saline or water, irrigation water, to wet the whole alginate so that you can actually remove it from the wound bed. Alright, so it will go back like a gauze. Now the last two words here which I actually mentioned to you, put it down here, a manuroric or gleneagles acid residue was actually contained inside the alginate. Okay, it's part of it. Now what is manuroric and gleneagles acid was actually, like I said, is part of the ingredient. Now manuroric was actually a fast-acting. I'm sure some medication have a fast-acting medication, you have a long-lasting medication, or you have a slow-release medication. Alright, so this alginate, it depends on the percentage. Like I say, different company will have a different percentage of this manuroric and gleneagles acid. Now manuroric acid, because it absorbs very fast, because of fast action, but the moisture's absorption maintenance is slightly bit slow. Okay, they can't maintain it, you know, they will just absorb and it's gone. But for gleneagles, it's actually absorption a bit slower, but it can help you to maintain the moistures there. You know, we need not just a very good absorption, but we need to have some form of maintain. Why? Because we created a concept called a moist wound healing concept. We don't want to make it too dry on the wound bed, so that the cells to be, the logic behind it is because the science behind it is because the cells need to grow. Alright, we need to produce a conducive environment for the wound cells to grow, so that such as the optimum temperature, such as a moist balance, so that the wounds can heal. Of course, nutrients, of course, oxygen supply, alright, to the wound bed itself. So manuroric is something fast acting, gleneagles is something slow acting. So there will always mixture, but the differences in terms of the ratio differences, that's how every company, almost all the company, a dressings company, they also sells you calcium alginate, but with different compositions of this. Well, that depends on the types of wound that you see. Now, this is the types of the dressing, the way that it looks like it, all right, like a fibre, and you can see that it causes a bit of bleeding. After that, it will be able to be stopped. Another one is hydrocolloid, which is on the tip of the triangle, which actually able to absorb a bit low exudate, not too high. All right, if of course it can have a barrier, bacterial barrier, and waterproof. The disadvantages is unpleasant odors and forms a yellow liquid gel. Now I always get referrals from the a junior doctor saying that after using this dressing here, when they're trying to remove it, they change it to a new dressing, it's always have this kind of yellowish liquid which look like a pus. Then they say that, oh, the dressing causes pus formation. I say, is the patient infection? No, patient is actually good and not even having fever. It's actually all right. But I said, this is not infected. It's not even pus. It's just because of the gelatins on the hydrocolloid was actually melt because of our body temperature. All right. So this is a drawback of it, but it's good for us. But it's good knowledge for us. So you have various types of a hydrocolloid that was actually sold in the market, and you can see that. All right. Some you can have a better viewing, better visions of the wound like this, and then some you just cover up, you can't even see, but you can see that once it change color, become whitish in color, that is the time that you may need to actually change the dressing. And of course, you look at the exudate level, the white, the changing of the color, is it same as the wound size or more than the wound size? That's how we actually trying to judge whether is it time to change. Right? So we also can, a lot of people have been using it for pressure ulcers, which I would suggest that may not be, but superficial can. But if they say this bad sore was actually developed into a deep ulcer, hydrocolloid dressing like Duoderm, CGM, Duoderm are not suitable at all. Now another one, non-woven fibers, people always knowing that it was an aquacell or hydrofiber. Why I say non-woven fiber, because this is not a company terms, it's more on the medical terms. And then the CMC is not our usual CMC antibiotic ointment, it's actually carboxyl methyl cellulose. Okay, it's a type of ingredient when they contact with solution, it will become gel form. Okay, just like our water, you want the water become gel form, you add this carboxyl methylcellulose. All right. So it helps in terms of absorb moderate to heavy exudate, maintain moisture sealing, non-traumatic upon removal, but it's not helpful, especially with a dry wound. Why? Because it will act like a gauze. It will stuck on the wound bed, and you trying to forcefully and remove these fibers, patients will be in pain, like aqua cells or liquor cells. Okay, these are the types of materials that was actually non-woven fiber with CMC. All right. So you can see that like more form up in the gel forms. You can see the wound bed. This is the one that was sticking on the wound. Actually, how do I know whether it's time to change? If you can see this is a whitish color at the edge here, well, we can change it. But otherwise, this is like fully very soaking like this on your left hand side. Is the time for you to change. You don't want to change, you have to change it as well. Okay, it's not up to us, but because this is fully soaked already. Now, another ones also can have a very high absorption, that is a foam. Okay, it also can have a cushion and conforms the body controls, provide protection, bacterial barrier and waterproof. However, it will also adhere to the wound bed if the exudate is dry. You also finding a hard time to remove it. You need to moist the foam, just like how we moist the gauze before we can remove the last pieces of the gauze which was actually stuck on the wound bed. Alright, these are all the foam in which different companies that they also selling all types of foam with different types of technology. Some have a silicone base, some doesn't have a silicone base. You know, some have a 3D polymer starch. How do they lock the exudate inside the foam materials? So all these companies have a different the central part here, the middle parts here. Okay, you can see the middle parts here will actually have a different types of ingredient. That is the difference. That's why they have different material that sells in the market. Okay. So another one talking about infections. Okay, you can have antimicrobial, a topical. We talk about topical. Here I'm not talking about systemic. All right, which I believe you guys may be more expert than me. And silver dressing, honey dressing, iodine dressings as well. Now, silver hedging is reduced bacterial burdens. Okay, in discoloration, which is a disadvantage, it can have a cytotoxicity. Now, these are the types of silver dressings that you can have, as long as it look like a silver color. And of course, you can have a silver paste, like a gel form that you can actually trying to squeeze into a cavities where you have difficulty to put this kind of dressing into it. However, this one was actually published by Professor Joachim Desmond, a German dermatologist in Germany. All right, published last year, was actually talking about resistance mechanism or silver resistant organism that was actually slowly developed. At this moment, if you ask me whether they cause any clinical impact, if I continue using silver dressing, topical silver dressings, no, at this moment. But however, just like antibiotics, the moment we heard about microorganisms, multi-drug resistant microorganism, okay, for antibiotic itself. All right, so still got a lot of people still using antibiotics. At this moment, the impacts in terms of clinical, even though if they are microorganisms develop a silver resistance, the impact is not that great for the time being. But why this guy was actually prepared and published it, just to make us aware that is it necessary all the wound that not healed always infected? It may appear redness surrounding, it can be inflamed due to various reasons. It can be injury, continuous injury, there's some assault onto the wound bed that we have to identify, or it can be vasculitic changes because of underlying connective tissue disease where the microvascular complications, due to diabetes, not just connective tissue. All right, so that's why hypoxic damage, there is an insult on the wound bed, so that's why the wound bed was actually redness in color. It's not necessarily redness equivalent to infection. So this guy was actually trying to raise an awareness for all the clinicians, especially for us who are specialized in wound management, to understand, is it necessary all the wounds that we need to give silver? Honey dressings, yes, you can have various types of honey dressings, and then with different companies as well, and also different ingredients. Some may have 100% honey, or you can make it as a coffee, but it's a very expensive coffee maker. So otherwise you can have 80% of honey content and things like that. So iodine also can have antimicrobial activities. Now if you ask me about all these three antimicrobials, which one have the best efficacies in terms of antimicrobial, I would say iodine, then followed by silver, then followed by honey. There are actually systematic reviews on these combinations of these three antimicrobial was actually been published in the year of 2017 and 2018. I believe that maybe you can Google, from a Google scholar, you may find some articles on this. Now film dressings is actually just a very thin film of a film, bacterial barrier, or majority we use it to secure the dressing. But the disadvantage, because of a fluid collection, it will easily leak out because it cannot hold so much, because there's not much of absorption properties. So these are the film dressings where some people secure the granular, but for us, majority we're trying to secure the dressings. However, if we have a superficial, like this top picture here, very superficial, yes, you can actually use it. Remember just now I said during the Second World War, the doctors in the prison, okay, was actually using this so-called film. Okay, this is what I mean. This is the film, adhesive film, to put it on the burned soldier, a prisoner. Okay, and then by the time when they remove it, they don't feel much of the pain. You'll be surprised. So this is what we call the film dressings here, was actually helps you to have maintain a certain amount of moisture, but not too moist. Charcoal dressing, nothing much, just to maintain the smell. Okay, of course you can have a collagen dressings. If we talk about collagen dressings, we talk about like the moisture which is towards the polyphilic, like a stage 3 already, or the phase 3 of the wound healing process. And of course, multifunctional dressing, we call a polymeric membrane dressings. The most important thing of this polymeric membrane dressing is anti-inflammatory functions. I love these products. Okay, why? Because not all the material they talk about anti-inflammatory, but this product is actually talking about anti-inflammatory. So if I have a very low threshold of patients in terms of pain management, or some of the palliative management, patients may be thinking of using it. But the drawback is that it cannot absorb a lot of exudate. Okay, there's a drawback of it. Now there's some of the adjunct therapy like hyperbaric oxygen therapy, which I think the introducer have introduced, which I send my patients for hyperbaric oxygen therapy, and that's me. You can see that, and there are my patients that was actually was being sent to the Navy-based hospitals. And this is where I received my training for hyperbaric medicine in Sydney, in Australia. They look like a room. They don't look like a chambers, actually. Okay, so of course negative pressure wound therapy, or in short we call a vacuum dressings. This is actually more towards in the hospital base because it's big, but the bottom part is actually you are able to carry at home because it's small, most probably smaller than your handphone. Alright, so by looking into this, I think it's time for us to look into like how are we going to using the time, assessment to talk about wounds like abdominal wounds. We graded like granulation tissues. Look at the granulation tissues here, and less than 10%, majority of them are sloughy, no signs of infections, or maybe there are a bit of an exudate. Healthy surrounding skin tissues. What are the dressings that we use? These are the dressings that we use, like cleansing agent, hydrogel, hydrofiber, from, like I said, transparent film is to secure the dressing itself. So you can see that from the bottom parts here, necrotic tissues, towards after debridement, putting some hydrogels, the dressings, and you will slowly heal, even though a bad sore like a sacrum. Alright, so these are all the dressings that we have. The challenges that we have is like the application of dressing always a challenging because we don't know what to choose unless we go into it and try to study the types of material. Understandings of the wound management is actually scarce because we never learn it from undergraduate. Okay, but it's only, like I said, during these past 50 or 60 years that things have been coming up because a lot of people trying to study the wound biology. The wound management shortfall is that because there's not much that we can actually learn it from, and practical is abundant but lacking of guidance. I'm sure from day one itself we're managing wound, but who is the one who guides us? I think most probably the nurses, but how far they can actually understand about this. Now my suggestion is that maybe you can attend some courses, do some attachment, or refer to the centers with the wound specialties. Alright, I think I have finished some of my slide introducing and the updates of what I've gone through. So hopefully that you guys can benefit from it, and that's my email. But before I talk about my case study, let's look at the time and see whether there's any time limitations. Alright?
Alright.
So back to the Lucia.
Thank you so much, Dr. Yap, for the interesting updates. We actually have received one question from the viewers. This one is from Dr. Tien Wei Kiong. Dr. Yap, how to handle exudative wound apart from hydrocolloid and foam product? And what are the modern dressing that need to avoid that potential to cause the wound become more exudative?
Okay. Now, first of all, why exudative in the first place? There are a few factors. Like I said, inflammation is one, and of course, infection is also one. And second thing is, what about hypoalbuminemia, such as like cancer types of patients, or some of the patients where they cannot have a proper food diet, like stroke patients, where they can only receive nasogastric tubes, a tube feeding. That's what we call a tube feeding. This is the reasons why in my master programs we have actually 1 hour lectures talking about nutrients. We need to get adequate protein intake for the patients if let's say we suspect of hypoalbuminemia secondary to malnutrition. Alright, then once we get up the protein, usually the exudate level will actually slowly reduce. I have this experience especially for a stroke patients or a brain injury patients who are actually bedbound. Okay, one of our medical staff was actually having this problem, encephalopathy. So he had unfortunately developed, I think 11 or 15 pressure ulcers from the head all the way down to the leg, at the back of his body, not in the front here. Okay, because of bedbound. So by looking into it, if let's say 15 ulcers, how am I going to use this kind of a modern dressings to dressing all the 15 ulcers? I just use what? Conventional dressing. Gauze. Paraffin gauze. That's all I use. But I asked a dietitian to come into play. Can you help me to calculate how much he actually consumed right now? And I need this amount of protein for a patient. 2 weeks later, all the necrotic tissue become granulation tissue. Of course, we add on hydrogel. That's it that we have. Cover up with gauze only, but no other modern type of dressings. Okay? So, now if let's say you can eliminate these kind of risk factors, inflammations that you can settle, but you still have a bit of this exudative wound. Like I said, hydrocolloid is not appropriate if there's an exudate, it become moderate or high. You can choose hydrofiber, non-woven fibers with CMC, the aquacell types, or the alginate types, cover up with foam. Alright, cover up with foam. Okay, from my experience, I'll be using like biotin foam, Askina foam, or Mablex border. Okay, Mablex foam. These three foams that I commonly use and have a very good absorptions in terms of management of exudate. However, if the patient's affordable, or if you think that you don't want it to have a frequent change, as in like, okay, this kind of dressing you can actually keep it for about 48 hours. You can change it for 48 hours. But somehow patients have a low pressure of pain. I don't want to change it so often. What can I do? Yes, like I said, adjunct therapy such as vacuum dressing. You have a portable vacuum dressing. As long as the patient's able to financially is able to look for this, they can actually look for this vacuum dressing. There are so many types of it available in the market. We can actually carry it, okay, at home, or no need to be too bulky. Or some people they prefer to rent because you don't want to buy the machine. You just rent the machine; they will give you the material. So that vacuum dressing, you can keep it there minimum 3 days, maximum about 5 to 7 days. Now, my experience is the longest is 5 days. Why 5 days? Because the longer that you keep it, because it created a negative pressure, sometimes the foam that we use will adhere on the wound bed. When you try to remove it, it can bleed a bit. You know, it will bleed a bit. So if let's say we do it at home or home visit, you don't want to be bleed. So you have to tell the people may need to change the wound dressings for about 3 to 4 days later. So maybe about like twice a week or once a week. That's the dressings, and it can help you to go for a very good exudate management. All right. Of course, if you ask me about negative pressure for vacuum dressings, studies shown that negative 120 millimeter mercury to negative 125 millimeter mercury will provide an optimum negative pressures for an optimum growth of the fibroplastic tissue. However, that studies, you have to look into the detail. How do they design a study? I have an experience, even though negative 75 millimeter mercury and the wound still close, not even negative 100 millimeter mercury. So even though you want to put it there, also can, as long as the patient is comfortable, whether you use a continuous or whether you use an intermittent. Now, for me, continuous, if the patient are low threshold of pain. Intermittent, if the patient doesn't feel any pain, you want to go for intermediate, you rest a while and then you suck again, rest a while, suck again, by all means go ahead. It will actually promote the granulation tissue much more faster. But the patients have a bit of pain, little bit of pain, they cannot take it, you might as well go for continuous mode for yourself. I hope this will answer to you.
All right, thank you, Dr. Yap. We have few questions coming in. This one is from Dr. Adlan Suhaimi. What dressing is recommended for superficial burn wound with no signs of infection in a lower limb, whole thigh, injury with no comorbidities, doctor?
All right. If you don't have anything, just like I introduced to you the transparent film, the adhesive film, if you dare to use it, you actually can use it because it's superficial burn wounds, of course. But of course, you have to assess the degree itself. Okay, whether it's the first degrees, second degrees, partially full thickness burns or something like that. But I believe full thickness burn you may need to refer to the plastic surgeons or whoever in a tertiary or secondary specialist hospital itself. Now, if let's say you are able to manage it in an outpatient setting itself, as a clinic itself, other than a transparent film, which I've seen, even though in our hospitals here people have been using it, like some of my colleagues in Sarawak GH, they're also using it before, and actually can help you to reduce the scarring effect, especially like face. You know, you're trying to put the transparent film, and people may say when you're trying to tear it off, a patient will be pain because the whole transparent film is sticky. No, the moment they contact with the exudate, the stickiness will just be off. So you can easily just remove it. All right. The other dressings which I didn't introduce deep enough is the regenerative medicine, regenerative ointment, which is a Meebo. Meebo also can help. Actually, Meebo designed for burn patients. If you look at the histories, Meebo was actually designed for burn patient. You just cover up, and then the efficacy for that ointment is only 30 hours. So it's meant for daily dressing. Okay. It can have a very, very good regenerative because it helps you to make it short. To summarize, what Meebo did is like the moment they apply, they make the wound bed, the cells become a stem cells. So the stem cells will actually attract all the growth tissues there to grow the skin, the epithelial tissue. So that's why it creates less scarring effect. Okay, especially when you use a Meebo. And I think nowadays you can get it from even the retail pharmacies. They also have a Meebo ointments that is available. So I think these are the two. But if let's say you don't have and you have more other things, you can use aqua cells also can. But like again, you have to assess the exudate level, because once you put aqua cell, it can be sticky if the exudate is not too high.
All right. Thank you, Dr. Yap. Another one from Dr. Jason Ong. What is fluffy gauze method and how does it help in wound management?
Fluffy gauze is nothing much. It just provides some form of absorptions and cover up water for the suiting or the comfort, so that it can have adhesion. Okay, gauze designed for absorption. The dressings material that I introduced to you, which I have shown to you just now. If you talk about absorption, gauze is the best. Whatever absorptions that I introduced just now to you, like calcium alginate form, even though I said form can have absorb highly exudative wounds, gauze is still the best. Now, what is the problem with gauze? Because it cannot retain. So you need, no matter how many layers of gauze that you put on, the lower part of the gauze will transmit the exudate to another layer, another layer, another layer, another layer. So what will happen to the lower part of the gauze itself? It becomes dry. The outer part of the gauze will become wet. So there's the reasons why the people always chasing the nurses, please change the bed sheet, please change the gauze, because it's always wet, because it have a very high absorption rate. I think the design, like I say, it was designed during the war time because for blood absorption, so that the war surgeon, they can actually quickly to ligate the vessels or to stop the bleeder or something like that. So that's the design of it. Now when we come at fluffy itself, we're just trying to put it down there to absorb, but it's trying to reduce the adhesive part. Okay, so basically it's just maintain the moistures, not to say maintain, it's actually have a good part of the absorptions of the moistures and trying to reduce the adhesions part on the wound bed itself.
Okay, next one, doctor. This one is from Bay Hay. Is it better to use antibiotic cream or H2O2 or Usol to clear infection first before other dressing, doctor?
Alright, it depends on the types of wound. Yes, I do this. Like I say, sometimes I may not be able to cater the wound healing at the same time. So what I did is, like, if let's say it's infections, okay, when the patient is not favorable, I will control the infection. Now the infections part, whether you want to use antimicrobial topicals or antibiotic topically, like a mupirocin or Flagyl, even though I have people using Flagyl, which is a metronidazole, or you may be thinking of like using this H2O2, the hydrogen peroxide thing, or Usol itself. Now all these studies has been done, but they are not favorable in terms of the cell. Alright, that's why I say is, when I choose to use it, I use those as well. Then I don't talk about cells anymore. I'll just kill off the bacteria. Okay, let's control the infection first. Once the infection is being controlled, then I look at the wound bed again. If the wound bed was actually being dry, a bit of necrotic tissues on the wound bed itself, but I confirm the infection was being well controlled, I will rehydrate the wound bed again with hydrogel. Why? I want the cells to be alive, because I cannot have both things together. But if let's say I give a silver, if let's say I give other type of cleansing or antimicrobial cleansing solution, such as Prontosan, such as Octinacet, okay, then I can have both. I can cater for both. But what about honey dressing? Then I can cater for both. But to a certain extent, some of the wounds that I may not be able to cater both sides, that is the problem. Okay, I'm not sure whether I have time to go on for my case studies, because I think I only left about a few minutes left, right?
Yes, a few minutes more, doctor.
Okay,
Yeah.
but otherwise maybe next times I can share it to you, because some of the wound inside my case study following that, I actually look into the infection first before I change it to modern wound dressings.
All right. Okay, doctor, we actually have two last questions.
All right.
Yeah. All right. Next one. Can we use adhesive film immediately in burn cases, or is the exudate too much for such use initially, doctor?
Can. It depends on your assessment of the exudate level. If you want to use adhesive films, also can. But if let's say your burns management is actually handling by the plastic and reconstructive surgeons, I think it will be better for you to consult them first. But if let's say patients doesn't want to do anything at it for the time being, and you want to manage it for the time being at this moment, yes, you can actually use the transparent film, and you do not have any other things. You can actually use this transparent film immediately. Of course, cleanse it first, make sure you clean up all the dirty things, and you can actually apply on top of it. But whether the exudate level, it depends on your assessment. Okay, whether is it highly exudative, like I said, transparent film unable to accommodate even moderate to high exudate types of wounds.
All right. Okay, last one, doctor. This one is from Renewa, Dr. Renewa. Do you refer back to the primary team or plastic surgery team for split thickness skin graft once the wound bed is clean, or do you continue dressing, doctor?
Yes, I will refer to anybody's, because wound management is a multidisciplinary. Okay, It depends on my team whether they have the time to do all the grafting. Okay, I will definitely refer to them. My next case, my immediate case study was actually trying to tell you, I'm actually referring to the plastic team for a skin grafting. After I managed the tissue become fully granulation tissue, nice and clean tissues, I will ask the patients, I would like you to go for a surgery. Are you okay or not? Then they will ask me what type of surgery. I will tell them it's actually skin grafting surgery. Okay, if you are okay with that, because once you graft, you don't need to come back to see me so often. Once it's grafted, the skin is there, it will just cover up and you have a better recovery or faster recovery in terms of this kind of a slowly process. I will refer them unless they refuse or the surgeon thinks that they don't have the time because of the operating schedule is too full and they are unable to accommodate it. Then I will continue manage them until epithelize the whole wound bed.
Okay. Thank you, Dr. Yap. So that was the last question we have for today. Dr. Yap, do you have any last remarks for our viewers today?
Thank you very much for all your participation and thank you very much for all the overwhelming questions to me. I was very alert, love all these things because it's a learning process. Like I say, I always like to share because it's not so much about teaching. What I've learned, I think some of you may know about it, because sharing is actually good for us. However, I hope that when you come across this kind of wound, whether you are in a hospitals or whether you are in a clinic and outpatient basis, trying to identify the problems first before we talk about the management. Why? Because my hard experience or painful experience that the moment if the wound bed are not properly been done in the beginning, we have very difficult times. Not to say cannot, can. You need to take a longer time to change the wound bed to make it more favorable so that the healing process can start to initiate. Alright, so I hope that you can have a happy wound management, back to your basics. But otherwise, if you have any problems, I think that's my email. You can always come and contact with me. I'm happy to answer any problems or any questions that you guys have. Thank you so much, and thank you very much for the organizer for a nice platform that we have here.
Thank you once again, Dr. Yap Jiann Wen. Okay, for all doctors, please don't forget to scan the QR code at the end of this live by using your MMA Doctor Phone application to get your CPD point now. If you have any difficulties, to scan the code, please click on the link for doctors only in the comment section to confirm your attendance manually. And to all the Gleneagles Hospital Kota Kinabalu staff who are watching this now, please don't forget to click on the link which is specified for GHKK staff only in the comment section for your training purpose. And also we have another online CME live session with our sessional vascular and endovascular surgeon, Dr. Benjamin Leong, on the topic of recent advances in vascular disease of the lower limb on 19th of August at 6 p.m. Let me know if you're interested. We will share the details with you. We have come to the end of our online semi today. Thank you very much for watching and see you next time.